Warner, this is probably, what about using serotonin as a marker when you're on SSRI? Does it make a difference for SSRI on if you measure serotonin? Yes. Serotonin in people who use SSRI. Plasma serotonin.
First of all, for those who aren't familiar with SSRIs, they are usually the drugs used for psychiatric problems or depression and so forth, like
Prozac.
Zoloft, Prozac, etc. Theoretically, they shouldn't make any difference, and in practice, I haven't seen any difference. Although occasionally, very occasionally, I'd say rarely, it has been found that an unrecognized carcinoid syndrome could be provoked or unmasked by the use of an SSRI. Such an article was written a long time ago, but in general, they do not influence the blood level of serotonin to the point where it will be measured differently.
Okay? Dr. Campo, two quick questions. Do tumors change their uptake of MIBG or octreotide over time? And why would you use a systemic dose of MIBG versus an intra-arterial MIBG dose?
I haven't seen them change over time, the uptake of MIBG. As far as systemic versus arterial, the reason to use arterial intuitively is that you get more bang for your buck. You're infusing the MIBG directly into the hepatic artery. That said, people who have measured uptake find that it's up to 4 times difference, 4 times more, and others have said, no, it's just about the same as systemic, so more work needs to be done there.
Okay, Dr. Mitros, I had my tumor taken out in 2006. Do I need to go beat the pathologist into submission to restain my tumor?
It depends on what you're talking about for restaining. I would say if there was no proliferative index, that would be a reason to review it. And again, that might be either a mitotic count or doing the key 67, but I think that would be one key thing. If you're talking about chromogranin synaptophysin, probably not. It's probably well done.
Perfect. What is the importance of octreotide before being put to sleep, and does this apply to being put out for upper GI endoscopies or colonoscopies?
I would say that this is an upsetting and traumatic undertaking, and in any such situation, your endogenous release of catecholamines, in other words, you produce an increase in adrenaline, and that can be provocative to carcinoid crisis. So prophylactic
Questions are
advice
closed.
should be given.
Okay, so the answer is yes. Simple things like fillings in the dentist office, I say no. If you're going to have them have to dig out a wisdom tooth that's going to take 2 hours and they're going to have to drill 16 holes in your jaw, that's a different kettle of fish. You have urine jugs that you don't need anymore. Somebody wants to know what to do with them. I think they look nice on your Christmas tree. Is there a relationship between Raynaud's and carcinoid? No. Can full gastric bypass with Roux-en-Y have an effect on the diagnosis? Does it change your gastric? It shouldn't unless your duodenum is excluded. If you have a Roux-en-Y that excludes your duodenum, it may do that. So that's something that I don't think is well investigated. Not a dermatologist. What if you're not a carcinoid but a PNET? Do any of these talks apply? Dr. Ardell, is neurokinin elevated in some PNETs?
Not normally. There would be some peanuts that go on to produce different syndromes. They'll produce many peptides or many amines. and then it might be relevant there, but it's not a good diagnostic test at all.
Dr. Mitros, does Ki-67 make a difference in PNETs?
It probably does. I think, again, we have to, get it for each individual tumor system,
But if you have a Ki-67 of 60% in a PNET, it doesn't behave like a Ki-67 of 3%. So the answer is yes, it does apply to PNETs as well. What are the best biomarkers for determining METs in lung primaries, a booger? And not a lot of people in the United States know a lot about lung tumors. Eric Liu's working on developing a lungoid clinic in Nashville. The guy that we defer most of our tough questions to is Dr. Dan Granberg at Uppsala, Sweden. We use substance P and neuron-specific enolase. We look at chromogranin, we look at pancreastatin. I can tell you there is not a good biomarker that I know of. Richard, do you know any? Dr. Mitros, do you know any? Roy, do you know
We
any?
do a whole panel, and usually can fish out one or two that are significant. Pancreastatin and serotonin in particular are helpful in my experience.
Okay.
We find a couple more, but it's just maybe 10% of the tumors or 5% of the tumors. But if you get a marker, it's worth having, and one is gastrin-releasing peptide, GRP, and calcitonin gene-related peptides. So two quite unusual peptides can come from the lungs.
Okay, GRP is also called bombesin, and it's in the ISI book. Here's an important point. If you didn't catch it, neurokinin A measurement for prognosis only applies to midgut tumors at this point. This question asked about lungs doesn't apply. Next. Constipation for 2 to 3 years prior to PNET diagnosis. 2 years after pancreatectomy, still constipation. Gallbladder removal 1 year, still constipation. Is constipation a symptom? Yeah, of the being constipated. You need to get on a bowel regimen. Something that doesn't change through multiple therapies ain't likely to be influenced. If taking out your tumor doesn't make your constipation go away, if your tumor growing and recurring doesn't make your constipation worse, the chances is that it's true, and unrelated. Are you supposed to do blood labs before or after a sandostatin injection, and why? Remember, you try to do it when you're at the lowest sandostatin or somaxilene dose in your blood. It's called the trough. If you do it right before your next injection, that's the very best. Doing it right after can totally screw it up. Remember, the little spheres of octreotide are coated on the outside like a frosted flake with octreotide. You put it in your butt, and all that frosting comes off in your blood in the next 24 hours. So that it's called a wash-off effect. And if you go even an hour after you get your LAR injection, your octreotide level will skyrocket. Are the markers discussed this morning applicable to islet cells? We've already answered. Extreme fatigue, health. I see it all the time, Richard. Patients with neuroendocrine tumors say, I'm tired. I go home in the afternoon and I don't have an islet cell tumor or a carcinoid, and I'm tired. What about energy in people who have neuroendocrine tumors? Is it tumor related? Is it octreotide related? Is it just you're old and falling apart?
It's not very specific for any of these tumors. And so I can't say that there's any real reason for a small tumor, even if it's functioning, to make you tired. Of course, if you have a big tumor and your nutrition is impaired, or things of that nature, yes, you're going to feel tired.
Remember, if you have your ileum taken out, if you have your stomach taken out, your B12 level can go down. Remember, if you're on octreotide, that it can affect your T3, free T3, and occasionally it'll screw up your thyroid functions. You may need to be on thyroid replacement. My insurance only covers Quest Labs. How do I get CPT tested? You go and you call your insurance company. You talk to the patient advocate. You say that I need to have this done. It's not happening, chromogranin is fine at Quest, but it's the other tests that they send to Cambridge, which is a real problem because Cambridge, when we do split tube testing on Cambridge, are off the wall. They are not accurate on their neurokinins and pancreastatins. So if you go along in your neurokinin and your neurokinin is 20, and you suddenly get a blood test that says your neurokinin is 200, do not panic. First thing you do is look on the lab sheet and see, did they send it to a different lab? If they did, throw it out, start over again. What is an alternative to PPIs, Dr. Warner?
Well, you can still use Zantac, for example.
H2 blockers.
H2 blockers, yes. And you can also use antacids if necessary.
And don't forget, there is always the surgical procedure called a laparoscopic Nissen. You're overnight in the hospital and your reflux is gone. It is clearly more invasive, but for people who have Barrett's esophagus and they have that absolutely have to either have PPIs or Nissen, at least you ought to talk to your gastroenterologist about a surgical alternative to lifetime PPI therapy. What kind of criteria is used for liver transplant? Please ask that question to Dr. Ramon Rivera or one of the guys talking about multivisceral organ transplant. We'll do that later. How does one determine, Richard, when to move on to a different treatment modality? You've done your MIBG, they didn't respond, what do we do? How do we decide that?
That's the very important question because most of us who handle a lot of these patients know all of the modalities available. The big question is when to apply, when to make the decision to switch, which one to do first. There is no universal doctrine regarding that, but it's obvious when things are getting worse in one course of treatment, then it's obviously time to switch.
Okay, Richard, what do you think?
I think the same thing. I see this all the time with MIBG. It's time, it becomes time to switch when things stop working. Neurokinin and pancreastatin are excellent markers to follow that.
Okay, sorry, I had to hit Dr. Ogo on for a patient. Should a patient be treated with octreotide if they currently have no symptoms? I'm going to answer that. You remember the old mantra when the drug came out in 1983. Odo was the first person to use octreotide in the United States at Ohio State on a Vipoma patient. Everything was symptoms. Novartis talked about symptoms. They didn't talk about everything. But as we got to use the drug in the 80s and in the early 90s, we all knew, everybody who used the drug knew that there were patients who had dramatic changes in their tumor growth. And the patients on octreotide did way better than people who you didn't put on octreotide. It was really the study done in Europe recently by the PROMID study, thanks. And the PROMID study says, I give you a placebo, a shot in the butt that doesn't work, or a shot in the butt that's LAR 30 milligrams a month. Who does better? By far, the people who were on LAR do better, and they took people with both symptoms and no symptoms. Best marker for PNET. The answer is, what do you have? If you have an insulinoma that makes insulin, it's insulin. If you have a glucagonoma, it's a glucagon. If it's VIP, it's a VIPoma. Otherwise, PP, what else do you use, Joy, for markers for non-functional, don't know what it is, pancreatic PNET?
It's quite hard for the non-functional ones because some of them will not even secrete chromogranin A. But usually with a malignant tumor, you'll get chromogram A positive, but then you've got the problems of the PPIs and things like that.
Okay, Dr. Warner, in the case of peanuts, what does a chromogram test tell you?
Well, it helps to tell me if the tumor is really a neuroendocrine tumor, except there are exceptions. For example, insulinomas don't usually give a positive result. But when we have a positive, it helps to confirm what it is, and it helps to confirm response to treatment. And if it's very high, it helps to indicate a bad prognosis.
Okay? Two that we've already answered, I'll say it again if you didn't think, is Ki-67 or MIB1. Remember, the MIB is the antibody to do the Ki-67 test. Is it a diagnostic necessity? In PNETs, you heard it from Dr. Mitros, yes. Is neurokinin relevant to PNETs? No. Okay, Dr. Campo, can I-131 MIBG therapy used in other cancers such as prostate?
Repeat that? What
Can you use MIBG in prostate cancer?
No.
No. Moving right along, can you use it in something like a pheochromocytoma, a paraganglionoma, a vipoma, etc.?
Absolutely.
And more importantly, how do you know that?
Well, because neuroblasts are, and neuroblastoma, you forgot that one.
Okay.
They all take up the agent by the norepinephrine transporter mechanism.
How do you know
That's
that?
the perfect way to do it.
How do you know that? How do you know they take it up?
It's been known for years. I mean,
The answer is you do a scan. Moving right along. How do I know? It depends on whether the plane's flying from India. We discussed the current thinking relative to the efficacy of evastatin to treat new pancreas nets. Avastin. Well, I think that's Avastin. It's a clinical trial. Nobody knows the answer. Avastin has not been a real active agent in neuroendocrine tumors. Do you agree? You agree. Joy, what about Avastin in Europe?
I think it's showing some evidence in the pancreatic tumors, but not in the guts.
Okay. Blood tests from oncologists are not making it to ISI. Need a new oncologist, need a new lab. They sent to Cambridge. Why is ISI being blocked by labs? Pure economics. The Cambridge people do it cheaper than ISI. You know, hey guys, if you want a surgeon, I got Guido in the back alley who will take out your nets. I promise you he will take out your nets for $12 or less. That's what you want. Used to say that pancreastatin was very sensitive to pulmonary solids. I never said that. I don't know who that was. That probably was sleepy that day. Dr. Ardell, what is the response of the British medical community to the article in the Telegraph about the Swedish anti-cancer carcinoid virus? Next. We're not even going to talk about that. Dr. Mitros, would taking PPIs makes NETs worse, i.e., does the development of gastric ECL cell hyperplasia increase the incidence of NETs? That's a question. And now you have buccal gastrin. Does that gastrin that gets to your ileal net make it grow faster?
The answer is I don't know, but I'm worried about it.
Boy, you ain't the only one. The answer is don't do it and you don't worry about it. There, okay. Any data on what well, you guys need to learn to write. Active increase, that's actual. Increased risk for development of carcinosis, long-term PPI, never going to be studied because it's out over the counter, and I can't even get people to tell me the truth whether or not they take PPIs. They see me and they go, oh no, it's Wilton, he's going to ask me about PPI. Dr. Ardell, how does the most recent neurokinin data relate to the prognosis of islet cells? We've answered that 3 times. It doesn't. NETs only rarely happens in islet cells. Dr. Wolvering, if you've been in long-term use of PPIs, how can you control the elevation of CGA of gastrin? We'll take PPIs. Are there alternatives? Yes. Surgical alternatives, H2 blockers, antacids, control the diet, don't drink alcohol, elevate the head of your bed. What did I miss?
I think you got it all.
Dr. Warner, 20% of people who have NETs develop another cancer. You said that towards the end of your presentation. They missed the rest of that statement. Can you restate it?
Metachronous tumors, that means occurring at the same time, concurrent or earlier in your life or later, are increased in frequency, very much so in patients with neuroendocrine tumors, particularly carcinoids. And the mechanism is not clear, except that there are more chromosomal variations in carcinoids than in non-carcinoid patients. And similarly, some of those variations may lead to the development of other types of cancer.
Okay.
There's a paper has just been published this year from a group in Holland and the Netherlands from a man called De Herder, and it's published in endocrine-related cancer, and it's about that.
Oh,
They've
okay.
looked at about 250 or 500 patients with NETs and other tumors.
Dr. Wouter Van Herder.
De Herder.
De Herder.
Uh-huh.
D-E-H
E-R-D-E-R.
E-R-D-E-R. And he's from Rotterdam, I believe. Patient had a surgery in 2004, still here to tell about it, almost 9 years later. Was told by the pathologist that, oh my God, I have necrosis in a lymph node. Should I be out running and panicking? What does necrosis in a lymph node say, if anything, other than it's necrosis?
There is some concern that necrosis would indicate a more aggressive behavior. That's been best documented, I suppose, in the pulmonary, the atypical carcinoid. It doesn't seem to be as strong as the proliferative rate.
Okay. Quick question here. CT scans and Octria scans every 6 months. I'm a young person. If I do this for 5 years, am I going to significantly raise my chance of developing a second primary? I guess we'll ask our radiation doctor. I'm a United Airlines pilot. I fly twice a day from New York to Los Angeles. Who gets more, the person who gets an Octria scan or the pilot who flies back and forth to New York twice a day, every day, 5 days a week? The United pilot. So that's the answer to your question. Would you be a pilot if they gave you $100,000, $200,000?
Also, Gene, don't forget about MRI as a substitute for CT.
Yeah,
particularly in the
very important point. MRIs for the liver are the test of choice. You do CTs for disease outside the liver.
The airline pilot, pilots do indeed have a higher incidence of cancer.
Right, and here's our favorite pilot, right? I know I've flown with him, so I trust him. So, from a kidney disease point of view, does the use of octreotide screw up the kidney performance? No. But if you have renal failure, octreotide, remember 10% of the octreotide goes out the kidney. So if you have renal failure, your octreotide levels actually go up. Do tumors have inflammation? Dr. Mitros, you talked about it this morning. Lymphocytes in the tumor. Do you have evidence of other kinds of inflammatory cells in tumors?
Uncommonly, and again, usually only if there were necrosis would you have things other than lymphocytes.
Okay, and do SED rates get altered with tumors? Not usually. That's too long to read. Dr. Mitros, in staging, well, I only got so much time, guys. I can read for an hour, or I can ask questions for an hour. In staging, what does perineural invasion mean? Does it impact on prognosis? And can proliferative tests be completed much later? I'm going to talk about that one. Why don't you talk about perineural invasion?
many tumors, including the neuroendocrine ones, will travel along the coating of nerves. And in most tumor systems, that does increase or is a predictor of increased aggression. Again, it's not a huge one. Vascular invasion will be worse. I think the proliferative index is important. But it is one of many things that one would look at.
Okay, we've got 4 minutes. Keep me honest, timekeeper man. Have to have dental work, which includes a filling, tooth being pulled. Dentist wants to know what can be done. I tell people, take a rescue shot before you go. Most simple fillings, most simple extractions, I don't think you need anything. What do you think?
However, tell the dentist.
Don't use epinephrine. Right, use plain xylocaine, or plain Marcaine, or plain Carbocaine. No epinephrine. Good point, Richard. Thanks for the save. Could you talk more about inheritance of nets? Dr. Mitros, something you want to talk about? MEN, cartilage? Okay, so let's do that later. I have no idea what that says. Okay, so we talked about dentists already. If you have no, Richard, if you have no radiographic response, but the patient stays alive, what's the mechanism of action? Anybody got any ideas?
Well, oftentimes you see no radiographic response, or it even gets worse because of swelling, necrosis, that sort of thing. So oftentimes the anatomical measurement is misleading. I would prefer to look at molecular imaging.
Okay. Question to me, if you're on an octreotide pump, should you turn it off for your 5-HIA or marker? No, because that's where you live. Do it, don't change anything, because you're going to be the same on day 15 as you are on day 1. How are the tests and drugs priced? Holy shit, if I knew. What is the best ongoing blood test for peanuts? We've answered that already. When do you use Creon? Leanne Burns, our dietitian, is going to talk this afternoon. If you're on PPI, should you forego the CGA test? No. Just make sure that you sort of understand that it may give you serotonin. It doesn't affect. It only affects the chromogranin and the gastrin. Make sure you get a pancreastatin. That'll help you sort out things. What is the best screening test in the context of a rural emergency room? Pancreastatin, 5-HIA, I would guess. What is the criteria considered liver transplant? We'll get that later. Thank you very much. The next speaker, for everybody, Dr. Warner, Dr. Campo, Dr. Mitros, Dr. Ardell. These are our speaker gifts. Let's get one. Somebody I want to show everybody this because I'm so proud of this. I had nothing to do with it. That's why I'm proud of it. Dr. Obricio's son, Joel, is a glass artist. And he made a black piece and then poured liquid glass over the Florida zebra pin image and then engraved it to 2012 Net Patient Conference, New Orleans, Louisiana. Joel Obricio did these for us.